and I am thrilled to have you all here. We have people from actually all across the world with us today, watching this very important video. We are thrilled to have a couple experts with us today who will help us and talk with us about, unpacking what we just watched, unpacking this very complicated disease, and understanding what's happening and how to get diagnosed, how to talk with people about it. So I'm going to just kick this off by introducing you to our two panelists. I am certain that in our next 34 minutes together, we will have so much to cover that I'm not going to take a significant amount of time, because in the introduction and the marketing for this, you did see the full bios of our physicians who are with us. But we're really thrilled to have Dr. David Shprecher. He is the director of the Movement Disorder Center with Banner Sun Health Research Institute in Sun City, Arizona. And Dr. Daniel Weintraub, who is a psychiatrist who works in movement disorders as well, who will be bringing a different perspective. We're really lucky to have a perspective of a movement disorder physician who focuses on Lewy body dementia, as well as other kinds of dementia and movement disorders, as well as a psychiatrist who can talk about this. So this is really very exciting. I'm going to kick this off with one of the questions that came up in the chat, and I'm going to just start with this one because I think it gives us an overview. Can you explain to us the difference between the different kinds of dementia? There's Lewy body dementia, there's Parkinson's with Lewy bodies, there's Parkinson's disease dementia. I'm wondering, Dr. Weintraub, if you could share with us a little bit about that.
Thank you, Sarah, and hello to everyone. I do think that is one of the most important and confusing issues currently, is the terminology that we use. And we need to make some progress to make things clearer, not only for us as clinicians and researchers, but for patients and families as well. There's an umbrella term called Lewy body disorder that includes both Parkinson's disease and dementia with Lewy bodies. And it's called Lewy body disorder because it's a disorder or disorders that are characterized by the presence of Lewy bodies in the brains of patients on autopsy. And those people that have these Lewy bodies can present during life as either having Parkinson's disease, so predominantly a presentation of a motor disorder, Parkinsonism, and they may or may not develop cognitive impairment, including dementia, in their lifetime, in which case they would be called Parkinson's disease dementia. Or those people with Lewy bodies can present initially with dementia or cognitive impairment and some psychiatric features in Parkinsonism, and those patients are likely to be diagnosed with dementia with Lewy bodies. Now, these disorders are overlapping. They're overlapping both in terms of the pathology in the brain that I just mentioned. They overlap in terms of course, they overlap in terms of presentation, but there are important differences as well. But the main distinguishing characteristic as of today, from a clinical standpoint, is the timing of the onset of the dementia relative to the timing of the onset of the Parkinsonism, the tremor, the stiffness, the slowness. If the dementia comes first and people have the constellation of symptoms that we're discussing, then they'll typically be diagnosed with dementia with Lewy bodies. If they present with the Parkinsonism first and meet criteria for Parkinson's disease, then they would typically be diagnosed with Parkinson's disease dementia if they develop dementia after that fact. And I just said a lot there, and I think it's probably still very confusing, but that's kind of the state of the field at this point. David, you might want to add from your perspective.
Yeah, and I often use the term Lewy body dementia because that's one that I think a lot of people recognize, and we hear it a lot. And it means that you have the Parkinson's changes in your brain, the Lewy bodies, if you have Lewy body dementia. And people who have dementia with Lewy bodies often have a much more aggressive course, and that's why it's an important distinction. So it's kind of a more aggressive form of Parkinson's causing dementia, meaning memory and thinking problems that are enough to interfere with everyday activities right from the start.
Great, thank you. It is complicated, and we have we have some additional videos that we can share with, we'll share with everybody who registered for today. And that way people who missed it would also have that, some additional educational videos. So thank you very much. Let's see, so there was a question about how do you get into testing? You know, in the film, they reference that quite a bit. They went in for testing and visits and doctor visits. Dr. Shprecher, what kind of tests are done when you're looking at this?
Yeah, the types of tests vary a lot based on where people are first seen. So when they're first seen in a clinic where they're being seen because their walking problems or their tremor, slowness and stiffness, the way that we approach the exam, looking for those Parkinson's type symptoms, may be a little different than if somebody comes to a center that's focused more on the memory and thinking problems. And in neurology, people are usually specialized in one or the other, and they're often teams that work together. So eventually, one might start with seeing a movement disorder specialist, but then get referred to also have that memory and thinking testing, we call the neuropsychological testing. We had a question come through, and I think it's a very important one to answer up front. There is not yet a brain scan that can show the Lewy bodies that are in the brain. So we don't yet have a definitive test to show there are Lewy bodies. That still requires eventually to have an autopsy if the person agrees to donate their brain for an autopsy or for research. But the brain scans available can help confirm if things aren't quite adding up, whether a person has decreased production of the movement chemical dopamine in the brain, or if there's reduced activity in certain parts of the brain. And there are certain areas that'll be more reduced in dementia with Lewy bodies, and in other people, if they mainly just had Alzheimer's, they'd be reduced in other areas of the brain. Those are important tests that we may use to guide the diagnosis. And we don't have, a time to go into all the details about every piece of information we look for in diagnosis, but another important test might be a sleep study, looking for evidence that people are moving their muscles or activating their voice box when they're in REM stage sleep, times when the muscles should be paralyzed. So those are examples of tests that we might use to help diagnose. But the most important test is getting a very detailed history and exam with a neurologist or geriatric psychiatrist specialist that's very experienced in diagnosing Lewy body dementia.
Great. Okay. And kind of along the same lines, there were some questions around, actual real diagnosis. And I think right before this started, we were talking about how, it's really the autopsy that confirms a diagnosis. So I'm wondering if you could share a little bit more about that. And someone took it one step further and asked, does Parkinson's disease and Lewy body dementia look the same on an autopsy? Or is there a differentiation?
Yeah, we do a lot of autopsy research here at the Institute here in Sun City. And so one thing I could just clarify is, yes, whether it's Parkinson's disease at a more advanced stage or dementia with Lewy bodies even at the earlier stage, there will be Lewy bodies throughout the brain. That's true in both conditions. One of the things that's confusing is as we get older, we can have more than one thing that goes wrong in our brains. And I don't want to kind of lose everybody with that, but we often do see Alzheimer's disease in the brain as well. About half the time in people who have Parkinson's and then develop dementia later on, we see a combination of Parkinson's and Alzheimer's, but it's the majority of our individuals who have dementia with Lewy bodies, at least here in Sun City, because we have an older population. Most of them are over 80 when they donate their brains to science. Most of those individuals actually have changes of both Alzheimer's and Parkinson's in the brain.
Wow. Okay. Thank you. There was a question about medication. So someone was talking about specifically the medication Mirapex, but talking about how medications can have side effects that can look like hallucinations, etc. Can those medications contribute to progression? Any thoughts about that, Dr. Weintraub?
Yeah, so we can go back and forth. Some questions may be easier for me to handle, or we can both weigh in on some of them. I would say that my experience, not as a movement disorder neurologist, but as a psychiatrist, is that for patients with dementia with Lewy bodies, they typically will only end up most commonly on levodopa, carbidopa, levodopa to help manage the Parkinsonism, so the tremor, rigidity, maybe gait and balance problems. They typically don't venture beyond that in terms of medications like dopamine agonists, of which Mirapex is one, is a dopamine agonist, and that is because of the side effect profile. And it's also true that the response to levodopa tends to be less for patients with dementia with Lewy bodies than for somebody who has what we call idiopathic Parkinson's disease. It's also true that even levodopa, if you get to a high enough dosage, can be associated with things such as hallucinations. So typically, I think dosages of levodopa are used at the lower range for patients with dementia with Lewy bodies to try to be careful regarding side effects. What do you think, Dave?
Yeah, I think the important question is, do these drugs actually contribute to progression? And I don't think there's clear evidence of that. But the problem is, if someone is only seeing a general neurologist who's prescribing drugs like this, or even worse, prescribing a drug like trihexyphenidyl or benztropine, which are actually anticholinergic drugs that are used for tremor in young people with Parkinson's. If someone's taking those medicines and the doctor doesn't realize it's contributing to hallucinations and other side effects, they can seem a lot worse and never seem to get better if that problem's not identified. So you really should, if your loved one has dementia and Parkinson's symptoms and they're taking a lot of medicines, not just carbidopa, levodopa, it might be worth getting a second opinion if they're not already seeing a specialist.
Yeah, I'd forgotten that point about the progression. I think that's a very good one. I think in general, we assume, or I assume, that most of our therapies are what we call symptomatic therapies, whether they're psychiatric or for the neurological conditions, so that once you remove them, any harm or adverse events tend to go away, and often relatively quickly. But in reference to David's point, which is a good one, I think there is some evidence from epidemiological research, particularly, that anticholinergic medications in the general population or in Parkinson's disease may be associated with worse long-term cognitive outcomes, which is why we're always on the lookout for a whole host of medications that may have what we call anticholinergic properties to see if they can be removed if possible.
Excellent, thank you. This is such a perfect example of the way the medical community should work, that collegial, like talking back and forth, especially with these kind of complicated cases. And I can't help but underscore what Dr. Shprecher said about getting to see, a movement disorder specialist, if you see a general neurologist, to make sure that you are really getting that advanced look into these complicated diseases. So along that line, and when you're talking about treatment, somebody did pose, boy, if he has all these resources and it was hard for him to get diagnosed, how do other people even begin to get diagnosed? And I'm going to start combining some questions just because we'll have way more questions than we probably have time for. But along that same line, okay, there may not be a cure. Are there treatments that are available that can help?
Yeah, and I think another way someone framed the question is, even with this diagnosis, what could Rob and his wife have done differently? And I think one thing we want to be upfront about is, while we don't have a treatment that's proven to slow the progression of the illness, if it's even for 1 or 2 years that we can restore quality of life, that's 1 or 2 more years where people can have meaningful time and participate in life with their families. And I think that's something that really requires someone that has the time and expertise to look for all the different symptoms. And it can be a specialist either in geriatric psychiatry, behavioral neurology, or movement disorder neurology that has a lot of experience with Parkinson's and Lewy body dementia. So I think there are a lot of different treatment options for all the different symptoms that were talked about in the video there, from the hallucinations to the acting out of dreams. Even the memory and thinking problems may, in the beginning, respond well to medication, sometimes even better than people with Alzheimer's do. And another important problem that's often missed in a very brief office visit with a neurologist is many people have low blood pressure when they're standing up, and they feel weak and dizzy and can't think clearly. because they're taking the wrong antihypertensives during the daytime, and it's making other things worse. So you really need someone who can look for that and address that as well.
I agree with David that a lot of the symptoms that were presented in the movie, that we may not be able to modify the disease course at this point, but we do have symptomatic therapies for them. And you never know if it's going to make a difference or not, but they can make a difference. And I thought the other point that Mrs. Williams made repeatedly was that it was just not knowing what was going on, what the diagnosis was. And I think that's incumbent on us as clinicians, providers, to be on the lookout for the symptoms that might tip us towards a certain diagnosis or lead us to a certain diagnosis, so that we can help patients, educate them, know what to expect. And I think that's as important as any treatment that we offer, is just helping to remove uncertainty about what's going on.
Yeah, absolutely. And how about, so somebody asked if you always have hallucinations with Lewy body dementia, and I'm just going to add to that also delusions. And if you guys can just take a moment to kind of explain the difference between the two, also for people who are maybe not familiar with that as a part of this. And I'm going to combine with that too. There was another question about if people with Lewy bodies and Parkinson's both have REM sleep disorder. So I think kind of differentiating to just, if you have REM sleep disorder, that doesn't necessarily mean you have Lewy bodies dementia.
I can start off with the first one because I'll start off with the first half because that's kind of a traditional psychiatric question. So from a psychiatrist standpoint, and it's pretty similar to, I think, the way most neurologists think of things as well, is there's an umbrella term called psychosis. And under psychosis, you have two main categories. And those two main categories are hallucinations and delusions. So hallucinations are an abnormal sensory experience. It can happen in any of your senses, taste, smell, vision, hearing. And delusions are a fixed false belief. So when somebody believes something to be true that most other people don't believe to be true. Unlike traditional psychiatric conditions such as schizophrenia, where auditory hallucinations predominate, in illnesses such as dementia with Lewy bodies and Parkinson's disease, it's visual hallucinations that predominate, although other types of hallucinations can occur as well. And then delusions occur, but even less frequently perhaps, and more in the advanced stages. And the most typical delusions would be what we call paranoia. So a belief that someone is trying to hurt somebody, or that a family member has been replaced by somebody else, or that the home that somebody's in is not their real home, those kinds of beliefs. In terms of whether everybody has these hallucinations, the answer is no. It's very common in dementia with Lewy bodies, but maybe about 75% of people at the time of diagnosis have visual hallucinations, but not everyone. And in terms of Parkinson's disease, we know that over the course of the illness, because it's often a long course, maybe 50% of patients or even higher have some type of psychosis, some type of hallucination or delusional belief.
Yeah, and there was a question also about this overlap with acting out the dreams. And it's a very complicated spectrum to sort out. What's a hallucination or delusion? What's sundowning? What's waking up and believing what you dreamed about was true, but that's really just a dream, and they start getting up and getting ready for work, trying to leave the house. So not everything that happens late at night when people are disoriented is necessarily a hallucination. It can be a form of disorientation that also has to do with trouble transitioning from asleep to awake. But when somebody is deep asleep, particularly if it's the second half of the night when we tend to have more active, vivid dreams, we call REM stage sleep. If they're screaming bloody murder, they're having an argument in their sleep, they're throwing punches and kicking or jumping out of bed, usually that's because they're acting out their dreams. That is something that can happen years before someone develops any other symptoms of Parkinson's or dementia with Lewy bodies. But it also can happen in a closely related condition, and even called multiple system atrophy, and even in some of the other conditions that don't usually cause REM sleep behavior disorder, except when they do. So to answer that earlier question, it's not 100% if someone acts out their dreams and they're diagnosed with REM sleep behavior disorder on a sleep study that they have Lewy bodies in their brain. They could have one of these other conditions, but the most common condition in that scenario would be a Lewy body disorder under that umbrella.
Okay,
I
that's
was just
great.
going to add one point to that, because this is really an important and active area of research to study people with idiopathic REM behavior disorder, or idiopathic RBD. So these are people that don't yet have Parkinson's or dementia with Lewy bodies. And what these studies have shown is that a very high percentage of those patients convert to either dementia with Lewy bodies or Parkinson's disease, and some of these other disorders, as David mentioned, but most commonly those two over about if you follow people for 15 years, let's say. And some of them convert to the cognitive disorder first, so that's dementia with Lewy bodies, and about half of them convert to the motor disorder first, which is Parkinson's disease. And it's a real clue to the illness, because we think that means the illness starts in the brainstem where the sleep centers are. But we don't really understand yet why some people progress more along the cognitive spectrum first versus the motor spectrum. But as we study this population more, we're probably going to learn a lot. And then eventually, when there's trials of medications, disease-modifying therapies, they're probably going to be applied at the stage of even idiopathic REM behavior disorder before people fully convert to dementia with Lewy bodies or Parkinson's disease.
So the earlier, getting people in earlier into those
Right.
studies.
Exactly.
Again, why it's important to have people participate in research and learn about these things. So that's great. So somebody asked about, are people with Lewy body dementia fully cognizant of their disease? Are they aware of what's going on? Is there insight into what's going on?
I can take a quick first stab.
Sure.
I'd say across the board, not just dementia with Lewy bodies, but I would say in dementias in general, when you have mild cognitive impairment or mild dementia, your insight is better than when you're later in the course of the illness, when you're impaired, when you become more cognitively impaired. So in the moderate to severe stages, because then people's cognition is impaired enough in terms of their memory and reasoning abilities and insight that they're just really not as aware of their limitations and symptoms any longer. But I would say in general, at the milder stages, there's better understanding.
Okay. Anything you wanted to add on that, Dr. Shprecher, that you?
Yeah, I agree, because and the caveat is also when someone has a delusion, that complicates things, because by definition, it's a fixed belief about something that's not true, even though there's clear evidence to the contrary. But yeah, generally later in the course, people may seem to have less insight than in the beginning.
Great. And I think there's a question here, and I know this is not necessarily in order, but I think it's a really important question, which is, there's the Lewy body disorders, right? But that doesn't mean that if you have a Lewy body disorder, you necessarily will have Lewy body dementia. Is that true? Because somebody's wondering, does that mean everybody with PD has some sort of LBD? That's not necessarily.
I can clarify. So
yeah.
Everyone with a Lewy body disorder has Lewy bodies in the brain by definition, and we still need an autopsy to confirm that down the road. But we diagnose based on symptoms, and if someone is at one end of the spectrum and they just have Parkinson's disease, if they live long enough, they eventually are likely to develop at least a mild dementia. Even following people from a very young age in their 40s or 50s, after 20 years of follow-up, 80% will have dementia. When people are enrolled at a later age, even within 5 or 10 years of follow-up, if they're in their 70s when they're originally followed, about 80% will have dementia in that follow-up period. So unfortunately, we don't have a proven therapy to prevent that, but we like to think keeping you socially and mentally engaged and getting regular exercise may be a helpful preventive approach.
Great. Okay. Someone posed an interesting question. They said, if you were Robin Williams' doctors, what would you do differently? And someone else asked whether or not it would have, there would have been an easier time diagnosing him. And I'm just curious if either of you want to comment on either of those things.
Well, I'll just say it's hard, one, from the video you're just provided limited information, and you know, it's easy to hindsight's 2020, or to be an armchair quarterback, as they call it. And I would be hard to say what would be done differently. I just wouldn't feel comfortable personally commenting on that.
Mm-hmm.
Yeah, we don't want to comment on a specific case, not having been directly involved. We certainly have our own specific approach when we meet someone initially, and what we always say is, you know, based on these symptoms, here are the possibilities, and then we want to do further testing to make sure we're on the right track. And the most important thing is to still have follow-up to make sure things evolve in a way that fits with that original diagnosis. And it's hard if we don't get to follow someone up to be right as often about a diagnosis if we only get to see them one time.
Mm-hmm.
Yeah, and unfortunately we, you know, in this case, the doctors didn't have a lot of time to follow him.
Right.
Very unfortunate.
So somebody could expect, if they did see, you know, either one of you or whatever, see a doctor that specializes in this, that there might be a conversation then leads to, you might list some things you suspect and then follow up with more testing like you've been talking about. That would be something someone could expect to have happen potentially if they meet with a specialist who knows about this.
Yeah, and I just want to add here, I think it is hard for dementia with Lewy bodies because there's not maybe a single home where somebody goes to when they present with these symptoms, because the symptoms can be varied. So if you have primarily cognitive changes, you may end up at a memory clinic. If you have psychiatric changes, hallucinations, for instance, you might end up with a psychiatrist, such as myself. If you presented with prominent Parkinsonism, for tremor, stiffness, you might end up with a movement disorders neurologist. So those are all a little bit siloed, so to speak. We all have our own areas of expertise, and we're stronger in certain areas than in others. And these people could also end up with a primary care provider who may have relatively little experience with this population at all. So that's just one thing that's tricky about dementia with Lewy bodies, I would say.
Mm-hmm. Mm-hmm. Somebody asked if sundowning is the same as hallucinations, and are there different kinds of hallucinations that people can experience, not just visual, but other audio hallucinations? Yeah.
Yes, sundowning is really first described, or most commonly described, I would say, in Alzheimer's disease, because that's the most common neurodegenerative dementing illness. And it just, I don't think people understand exactly why it occurs or when it occurs, which is typically in the late afternoon and early evening hours, if it has to do with circadian rhythms in some way. But it's not the same as hallucinations. It typically means that the person becomes more confused, just to use that general term, in those hours, and they may have more behavioral problems, be more agitated. And again, we don't know exactly why that occurs. And in reference to the other question that was asked, at least in Parkinson's, but I think even in dementia with Lewy bodies, visual hallucinations are the most common. Auditory hallucinations probably are the second most common, and then much less common than those, but they still do occur, are gustatory, which is taste hallucinations, tactile hallucinations, which is feeling something, and even olfactory hallucinations can occur, even though relatively few Parkinson's disease patients can smell or smell well. They can still have abnormal smell experiences.
Okay. You know, somebody put a question about the medications, and we'll put into the chat, just so you have this, on our website, we do have listed all of the FDA approved medications. There's little videos. In fact, you'll see Dr. Shprecher's on video in there about the different medications as well in the More You Know section. So there is some information specifically that you can access. We'll put that in the chat, but I'm wondering if you guys can share a little bit more. There's a question about medications, and also perhaps talk about some of the medications that are coming down in the pipeline, because it's something that is, I know you two are very actively involved in research in these areas.
Yeah, let me just say, I think that resource that the PMD Alliance has created is a great place to go to get more in-depth discussion of the treatments for the motor and then for the non-motor symptoms of Parkinson's and Lewy body dementia. I don't want to take up the last 5 minutes going into detail, but I think the question about treatments in development is an important one. We have treatments specifically for dementia with Lewy bodies with a couple of different companies, where what I recommend is if you live in a city that has a movement disorder or dementia specialty center, ask them what studies are currently ongoing to get involved in helping develop these treatments. There are treatments both for the cognitive symptoms in development as well as for the behavioral psychiatric symptoms. And I want to take this opportunity, since we have an expert in that second area of expertise, to hear from Dr. Weintraub about those.
I'd say that there's been more studies done in Parkinson's overall than in dementia with Lewy bodies for a number of reasons, and including behavioral and really cognitive as well. So the strongest support for treatment of things such as depression and psychosis comes from the Parkinson's disease literature, but we often export that into the dementia with Lewy body population, I'd say. I went on to clinicaltrials.gov just to refamiliarize myself before this session today, and I counted 7 studies that are ongoing or recently completed just for dementia with Lewy bodies, almost all around cognition, I'd say, not behavioral symptoms specifically, and all very novel mechanisms of action. And I know there's an equal number going on in Parkinson's dementia currently. So I would say this is a very, very active area of research, particularly cognition, but to some extent behavior or psychiatric as well. I think pharmaceutical companies are very interested in this area. They see a huge unmet need. They hear from patients and care partners and providers. And they're not just repurposing medications that we already use for Alzheimer's. There's some of that, but they're actually testing out many new novel compounds, which is really good to see.
Yeah, and thank you to both of you for the work that you're doing on that research. It's so important. And we were talking about some of those non-motor symptoms like this, and they're so complicated and usually the most challenging for people. And this is tied to that cognition question. Do people always progress from mild cognition to severe? Is that a guarantee that that will always happen for people?
From Parkinson's disease with mild cognitive impairment to dementia, or from mild dementia onto severe, that's a really good question. The answer is no. Not everyone progresses from one stage on that spectrum to the next, but people who have mild cognitive impairment are much more likely in the near future to develop at least mild dementia. And when people have dementia with Lewy bodies, they do usually progress through all of these stages from mild to moderate to more advanced dementia. That does not necessarily happen with everyone who starts with just Parkinson's and then has mild dementia later on.
And I think the other thing it's helpful for people to remember is that we focus on the cognitive impairment that occurs in these illnesses, and it does. But as David already mentioned, people can have other illnesses, including comorbid Alzheimer's disease, or they can have vascular changes from high blood pressure or diabetes. And in the general population, if you live to be 90 years old, there's probably close to 50% chance that you're going to have dementia from some cause. So if you live long enough, whether or not you have Parkinson's disease or dementia with Lewy bodies, there's a fairly high likelihood you're going to have some cognitive impairment long term.
Okay, and I want to let people know that we've been tracking these questions. So there are many, many questions we couldn't get to in our brief time. But that doesn't mean we can't have another live stream discussion about this. I think these are very good. These are complex and they're so important. They're so challenging for the person with the disease and also the care partners and family members, adult children, loved ones. We have been tracking them, so we will not forget that you've asked these questions. And by the way, everybody is invited to, somebody put in here that we're all invited, including you doctors, to a person's house to watch the father and have a discussion about that. So we'll get that on the agenda. But I'm going to end with a question just tied to sort of quality of life and self-care, which is really about exercise. Tied to Lewy bodies, does it stave off Lewy bodies? Or do you have any thoughts about the impact of exercise on a person with Lewy bodies? And I'll say the care partners too.
Want to go, Dave?
Yeah, exercise, through a lot of research, when we give a monkey a toxin that will cause Parkinson's disease, and it does, but then we have the other monkey runs on a treadmill for 4 hours and then it doesn't. That's an extreme example of where it looks like there's a probably a protective effect of exercise. We're not saying you have to go run on a treadmill for 4 hours every day, but there's a lot of evidence that exercise is good, not just for your general health, but protective for the brain. So we just need to figure out what type of exercise program is right for the individual. And we rely on our physical therapy colleagues to help design that program. And it's important that the caregivers also take care of themselves and budget their time and energy so that they can really pace themselves and have a support system in place.
Thank you. And I know we're just a minute over time, so I'm going to take us 2 minutes over time by saying, just asking each of you if you have any final thoughts that you'd like to say, and thanking you again for spending your time with us today. This was really helpful. Dr. Weintraub, do you have any final thoughts that you would like to share?
Well, I would say for people that are out there that are still seeking care or have concerns about a loved one, try to get help, the appropriate help in terms of a good evaluation. That's number one. You already mentioned, I think it's important to support research when possible. And there's all kinds of research that people can be involved in, but we rely on and are very appreciative for the efforts that people make when they participate in research, because it's our only way to try to understand things better and make progress in terms of treatment and hopefully prevention one day.
Thank you.
And I just want to say the kudos to Susan Schneider-Williams and the everyone who put this film together, because they're really just trying to raise awareness so that if you think that you or a loved one has one of these conditions, the PMD Alliance and the Lewy Body Dementia Association are great resources to connect you with the right specialists to investigate that further.
Well, thank you. And thank you to all of you for joining us today. Thank you to Dr. Shprecher, Dr. Weintraub. We did put into the chat their full bios, which has exactly where you can find them, should you want to track them down at where they work. But they are absolutely top-notch experts who are really trying to understand this. We're grateful for all of you. We will circle back with you and send you some additional materials and some additional links so that you have some reference materials that will follow up this presentation. Thank you for being with us today. It was wonderful to be with you guys.
Bye-bye.